Yeah.
Okay, good. I'll just... Can you see my slides?
Yeah.
Okay. Shall we start?
Yeah, I'm ready when you are. I think we'll start.
Okay, so good afternoon all. My name is Hala Danoon. I'm the Senior Clinical Pharmacist for Modern Hall Medical Centre. I'm an independent prescriber. I mainly practice within asthma, COPD, women health, HRT prescribing. Also part of the diabetic team and prescribing DOACs for atrial fibrillation. Today's presentation is about pharmacology. I thought I'll give you the basic information about pharmacology, how pharmacists or even medics look at pharmacology, what does it mean, what is it affected by, and then we will move after that to the specifics of asthma and COPD, how is pharmacology understanding affects the treatment management in asthma and COPD. So it's important to understand the definitions in pharmacology. So there's two parts. The first one is the pharmacokinetics, which is the effect of drug within the body, how it's absorbed, distributed, metabolized, and eliminated. So it's the effect of the body on the drug. The other part of pharmacology is the pharmacodynamics, and that's the effect that you want your drug to have on the body. Okay, so it's the interaction of the drug with the receptors inside the body. The main four aspects of pharmacokinetics is absorption, distribution, degradation, and excretion. So we need to know when we administer a drug, what's going to happen to it from the minute we administer it, how it's absorbed all the way until it's eliminated from the body. So there are slow absorption and fast absorption and extra fast absorption. So slow absorption is like the orally administered medication. The reason being because we need to swallow it, it needs to go into your intestines, it needs to be disintegrated, has to pass through membranes, which is your oral mucosa, nasal mucosa, etc., and that can affect the absorption. Also, topical and transdermal can take quite some time to be effective because it needs to pass through the skin barrier before we notice the effect. And the same with the rectal route. So although it is highly vascular within the rectum, still there is a time delay till it reaches to the blood. Faster absorption is through parenterally administered drugs, and that's whether through IV, IM, subcutaneous, and intraperitoneal. Now, as you can see from the different pictures, there's different layers where we need to administer the drug. So IV directly into the bloodstream. Intramuscular, we are administering it into the muscle mass. Subcutaneous, we putting it under the subcutaneous area in the skin, and that can cause a low distribution or faster distribution depending on the drug. And then we also have the intraperitoneal injections. There's also the inhaled route, and that is used mainly for respiratory drugs through inhalers or nebulizers. The fastest absorption is directly into the brain, and that can cause through intracerebral into brain tissue or intracerebral ventricular into brain ventricles. Now, the faster the absorption, the quicker the onset, the higher the addictiveness, but the shorter the duration, because you are sending it straight into an area, and then most probably there's a high bloodstream going in, and that means we'll high elimination as well. Now, there are things that affects absorption, and one of them is solubility. So some medication are water soluble, while others are lipid soluble. Water soluble means they are ionized, they have electric charge, so it might be difficult for them to pass through a membrane. They need to go through pores where there is a transport, While lipid soluble, they are non-ionized and they can cross the cell membrane more easily, and they can go for a blood-brain barrier through easily. Now, it's important to understand the solubility of drugs because once we know as a part of the pharmacology, you will understand the side effects. Like, for example, if it's going to have an effect on dizziness and drowsiness, concentration, is it going to reach through the intestine into the bloodstream more easily, or do we need to make a modification? So the way that we absorb drugs will affect the bioavailability. So bioavailability is the amount that reaches the bloodstream of the medication that we administered. Now, bioavailability is when we compare the route of administration, which is oral, versus IV. So IV will give you the full amount of drug that you administered into the bloodstream. If we compare oral, how much is going to go from that oral tablet into the bloodstream, and then do it as a fraction against the IV, then that will tell us the bioavailability of the medication through that route. Okay, so as I said, IV provides 100%, so F factor is 1, while subcutaneous, intramuscular, oral, rectal, or any other route of administration can have less of a bioavailability than the IV. Okay, and that can reduce the amount of drug that is being available for the effectiveness of that drug. So what is an absolute bioavailability? Now, the bioavailability of a drug after administration by any route is compared to its intravenous standard formulation. So that is the absolute, which is the F factor. There's something called relative bioavailability. Okay, so if we are looking at two different drugs and we compare them to each other, not to the IV, okay? So for example, if we have two different brands of the same medication, for this one we have the Tylenol and the Panadol. They're both paracetamol, but when we do the testing and we look at the amount of this drug into the bloodstream, we compare both medication together, and that's probably why sometimes you will have patients saying that this medication is working a lot better than the other. So although they're both marketed as, let's say, paracetamol, or they're both marketed as atenolol or any other medication, sometimes the excipients that is added to the medication can affect the absorption from the intestine. So what the patient is telling you, despite us telling them that, oh, they're all generic, they all should be the same, there could be a variation in the bioavailability and therefore in the effect of the medication or even the side effects. So it is important to get an idea of the different formulation or route of administration, that different bioavailability, as we need to sometimes do adjustment to the dosing when we are giving a different formulation. And that's why if we look in the BNF, you will sometimes find that it has to be prescribed by brand. For example, with Priadel, lithium, it says that we have to specifically prescribe it by brand because the absorption of the medication is variable, and because it has such a narrow therapeutic index, it's important that we continue with the same brand to maintain the same level. Other drugs is not important, especially if they have a very large therapeutic index, so it's fine to change brands. But when it comes to specific or narrow therapeutic index, it's always a good idea to stick to the same brand. And that is the same for inhalers, it's the same for the types of insulin, it's the same for, as I said, some branded like calcium channel blockers like nifedipine. There are different types of nifedipine, modified release. Bioequivalence. So what does it mean? That means two medication, when they are administered, they will have the exact same level in the blood. Okay, so they are exactly the same level, they will be calculated, and there's no difference between one product and another. So when we have a bioequivalent, it's easily to prescribe one other rather than the other, because we know it's going to have the same effect. For example, if we're talking about HRT, if I'm talking about the patch versus the gel plus the capsule, they both have bioequivalence. So I should be able to transfer from one formulation to another, as long as the dosing is equivalent as per the literature of both products. So bioequivalence is not always just about the same dose that they swallow, but it's also about changing from one formulation to another, reaching the same level. Factors affecting bioavailability. So there's quite a few factors that can affect the bioavailability, and that is the first pass effect, where the medication goes through the liver, gets metabolized, and then gets released into the bloodstream. Now, this is a major issue for quite a lot of drugs, and that's why we will see some patients have more of an effect of a medication than another person, because their first pass effect is stronger than another. That's why you see sometimes that the dose that we're giving is quite high, but the bioavailability of the medication is lower because it's going through a first pass effect. As we said, the route of administration has a lot to do with the absorption. So if a medication goes through the first pass effect through the liver, it might have less of a bioavailability, while if you administer that one through a patch or through subcutaneous, then the bioavailability will be higher because it is avoiding that first pass. Dosage forms as well, because it's very much dependent on the particle size, the disintegration, and the dissolution of these particles. So, for example, suspension might be easier to be absorbed than tablets, than capsules. It's the way that the medication is made, and other excipients, and if the body needs to break down. So, for example, if you have this medication in a suspension, it's widely available for the body to absorb it more easily. Well, if you have a tablet, you can imagine this is one solid piece that needs to be disintegrated into your in your stomach, and then it needs to go to your intestines and then gets absorbed. So the process is different. There's excipients, there's disintegration factors, and that's why they do quite a lot of studies when they do the pharmaceutical formulations, which one is easier to be absorbed and yet is stable as well. So we need to look at these factors when they look at formulating medication. The molecular weight of a drug, for example, if it's a big protein like insulin, can be absorbed through your intestine or not, or does it need to go through a different route? Lipid solubility, as I said, because that will affect if it's going to be able to absorb it through your intestine, or does it need to go through into your blood or through another route. The degree of ionization again, so highly ionized medication are hard to be absorbed from the GI, and we need to look at methodologies where we can suppress this ionization or find an alternative route. Drug solubility depends very much on the lipid solubility and ionization. So aqueous preparation are easier to absorb than oily, but again, we need to have almost like a balance between how soluble it is versus how ionized it is, how lipid it is. Chemical instability in gastric pH, like penicillin and insulin. Do we need to modify these medications where we need to add something to it to protect it against the gastric entities? Like a lot of medication are enteric coated, so it gets preserved into your stomach until it reaches into your intestine. The changes of this pH will help dissolve the outside of the tablet and then release the medication. That's the same with penicillin and insulin. Now, there are medications that has depot binding, so they accumulate in a fatty tissue. Now, this can sometimes be beneficial, where we want it to be binding to give us a slow release. But sometimes this binding can cause reduced bioavailability, can cause slow elimination. So sometimes it can cause toxicity if we're talking about a medication that is staying in the blood. However, let's say the active ingredient is not reaching the treatment level. So the patient is not getting the relief they are expecting from this medication. So another dose gets administered. Now, if you imagine some of it is left in the muscle because there's a depot, and another dose is added, you might reach into a higher level of medication in the bloodstream, leading to toxicity. So the elimination is slow accumulation, and that can cause some problems if it has a narrow therapeutic index. Also, depot binding drugs can be released during sudden weight loss, which may cause some flashback experiences. Again, like maybe can cause some toxicity. What other factors can affect absorption? The surface area available for absorption. So we know that the small intestine has a large surface area, more than the stomach, so it can increase absorption. So medication that is absorbed, if it travels through the intestine, has a better chance to be absorbed. Blood flow to absorptive site again has a high impact on the absorption. So if you apply, for example, a topical treatment to somebody who just had a shower and the skin is still quite warm, they will absorb that medication much faster than somebody applying the same patch on a cold skin. So that's why sometimes we tell them do not apply it immediately after a hot shower. So the greater blood flow increases the bioavailability, and because the intestine has higher blood flow for absorption purposes, there is again higher bioavailability through the intestine. If there is a long transit time in the intestine, then there is a high chance of absorbing it. But if a patient has diarrhea, then that reduces absorption, and this could be very important for women who are taking the contraceptive pill. So if a woman is having diarrhea, the contraceptive pill can have no effect and then increase chances of pregnancy. Food has either an increased effect on absorption or a reduced. It's very much dependent on the drug itself. So you'll find some medications say take on an empty stomach, while others say take with a meal. Not only for the purposes of absorption because of food, but the effect it has on gastric emptying, dependent on the drug itself, if it's soluble in fat or if it's water soluble. So generally it slows absorption, but some medication it will increase, like rivaroxaban. We tell the patient that they need to take it with main meal, because if they do not take it with the main meal, it would reduce absorption by 60%. So that will affect the bioavailability and protection against a stroke. Tetracycline, aspirin, and penicillin V. So aspirin needs to be taken with food because it protects the stomach. Tetracycline and penicillin on an empty stomach. Fatty meal increases absorption of fast-soluble antifungal like risovolvin. It also increases absorption of vitamin D, because we know vitamin D is a fat-soluble vitamin. So when I give advice to my patients, I tell them to have it with a nice big meal. The same as we said with the rivaroxaban. Distribution. So now that we administered the medication, we need to see how it goes into the body. So you have a drug administration, it goes into absorption, and then that will go into the blood. After that, it will go to extracellular, outside the cells, and then intracellular. So there's that distribution from the drug being administered into the blood, and then where it goes in the body. Are we trying to send it inside the cells, outside the cells? And then that will involve some calculations for pharmacists. Now, this slide shows you the different routes of administration on the left-hand side, whether it's oral or rectal, goes into the gut, percutaneous goes into the skin, intravenous goes straight into the plasma, intramuscular, intrathecal, and inhalation. So pretty much, you can see all of them will go straight, not straight, they will go into the plasma, but if you look at the oral and rectal, they will go through the portal system into the liver, and they have the first pass process, and that's where the bioavailability could be reduced. Even inhalation can go through that same route as well. Then it will go into the plasma, and then if you look on the right hand side, now this is where we start to balance things with the plasma, where we start to excrete more through the kidneys and through sweat and the breast glands. So, and some of them will through feces as well. So you absorb, distribute, and then you eliminate. Now, if we're looking about degradation and excretion, one big major organ in the body that is responsible to detoxifying the body and eliminating the medication is the liver. Liver is very rich with enzymes that help metabolize food plus other chemicals that gets into the body. The main one is a cytochrome P450. Okay, so it changes the medication into more water-soluble metabolite that gets excreted through the kidney. Repeated drug exposure increases efficacy and tolerance. So if you get like diazepam or any of the controlled drugs, if we get repeated exposure to this medication, sometimes we end up with tolerance where the dose has to be increased. As I said, as the metabolites change into a more water-soluble metabolite, the kidneys will then eliminate it through the fluids that gets excreted from the body, and whether that is through the urine, which is our primary excretion system, through feces, which is more through the metabolite. If they go into the bile, then get excreted into the guts, through air, through exhalation, and through sweat. Other excretion routes is lungs, and that's why they do the alcohol breath testing, through breast milk, and this is why important to understand the medication if they get excreted in the milk in high quantities, because we need to give specific advice for certain medication. And one of them is the contraceptive, where a woman who is breastfeeding and had unprotected sex, and she calls us for a medication. One of them that can be given within 5 days gets excreted quite a lot in the milk. And we tell the woman to withhold breastfeeding for 5 days, and then she can express, give the child formula, and then 5 days later she can breastfeed again. Now, acidic or high iron can be excreted into breast milk. Alcohol has same concentration as blood, and antibiotics, some of it can be excreted through the breast milk. We said bile, skin, and saliva. These are your other fluids that can contain some of the metabolites of the drugs that we consume. Now, metabolism and elimination. There's something called half-life, which is the time it takes for the level of the drug to drop by 50% from the initial level. Whole body half-life is the time it takes to eliminate half of the body content of the drug. Okay, some factors can affect the half-life, which is age. The older we are, and this is when we grow over 60, then the half-life will be increased because we do not eliminate it as easily. So age, renal excretion, that's why when we have patients with renal failure or reduced renal clearance, we need to reduce the dose because that will affect the elimination. Liver metabolism, patients with liver diseases, again, they can have problems with eliminating these medication. And protein binding. So that was kind of like a brief go through the general principles of pharmacology. I try to keep it simple and make sense of things. Any questions before I move to the pharmacology in asthma and COPD? No questions? Okay, so I will go back to the screen. Okay, so now we're talking about the pharmacology in asthma and COPD. For us to understand medication, we need to understand the condition and the medication and what causes these conditions. So asthma is a chronic inflammation disorder of bronchial airways that results in airway obstruction in response to external stimuli, which could be pollen grains, cold air, tobacco, smoke, animals, perfume, emotions. The list is quite long, and because it's inflammatory, it's variable. Okay, so it's not a steady line. The main characteristics of airway obstruction or restriction in patients is they have airway hyperreactivity. So they're quite sensitive to the airways due to quite a large range of external stimuli, as I mentioned. This can cause inflammation. So inflammation will cause swelling, thickening of the mucus production, bronchospasm, constriction of the bronchial muscles. So all of these symptoms will cause what we call the inflammation and then the symptoms of asthma. So if you look at those two different dissection of the bronchioles, you will see that the one on the left is a normal airway with a nice lumen open. The muscles around it are nice and thin, and the mucus as well. While the one on the right-hand side, you can see that there is an inflammation with a narrowed airway lumen. The muscles are quite tense and thickened. There is also tightened muscles which constrict the airways, and these will cause the problems of breathing. So that leads us to the symptoms of asthma. So asthma produces recurrent episodic attacks of acute bronchoconstriction. So patients will suffer with tightness in their chest. They are struggling to take a breath. They can have chest pain as well, and wheezing and rapid respiration. Cough is a main symptom that can help us to have a clinical idea of what's going on through history taking. And the symptoms can happen each time the airways are irritated by inhaled irritant or allergy. Okay, so these symptoms can be significant for patients with brittle asthma. Now, what causes these inflammation? There are different stresses or different triggers. Infection is one of them. Infection can cause increased inflammation. And even though that the infection can go away, the inflammation can last up to 6 months. Emotional conditions, so stress and anxiety, if a patient is already asthmatic and they also have anxiety or stress, that can increase inflammation and that increases the possibility of having an asthma exacerbation. The same with stress. Exercise is also a common factor, especially in children where there's exercise-induced asthma. Pets, mainly with hair, because that can cause a trigger. Seasonal changes. Some drugs like aspirin and beta blockers can also cause exacerbation of asthma. Airway innervations. So there are two types of sensory or nerves within the system. The first one is the afferent nerve, the sensory, and it normally affects the upper airways, C fiber receptors and lower airways as well. And these are stimulated by exogenous chemicals, physical stimuli, which is cold air in winter, and endogenous inflammatory mediators, especially the C fiber receptors. There's the efferent nerves, which is the motor, and this is affected by the parasympathetic supply, which is in the smooth muscles and gland. So these are causing the constriction. So one of them is the first one, the afferent, is by the stimulation of histamine, of inflammation, while the efferent, which is the motor, is affected by the muscles themselves. No sympathetic supply, but beta-2 receptors in smooth muscles and glands. To make more sense of this, so this shows the bottom of the slide shows you the epithelium of the lungs. As you can see, there is some cilia, there is some mucus, and there is irritants because of the cigarettes. It has no cilia on the epithelial cells. There's a smooth muscles that's affecting the contraction of the lungs, and it's all connected to the CNS and to the ganglion. So mediators can have an effect, a direct effect on the C fiber receptor and also on the muscles. And the CNS can also affect the acetylcholine and the production of mucus. Okay, so these kind of like route will show you how the inflammation can affect the exacerbation of asthma. So what is the aim of the anti-asthmatic drugs? The main thing is to relieve an acute episodic attack of an asthma, to give them a quick relief of their asthmatic attack, to make them breathe better then and there. Then we try to aim to reduce the frequency of attacks, and that's by maintenance medication. We also try to reduce the nocturnal awakening, because they're coughing throughout the night, they're not breathing that well. So we're trying to give them quality of life by opening up the airways throughout the day and night. So what are the anti-asthmatic drugs? It comes into two different categories. One of them is the bronchodilators, and these are affecting the smooth muscles around the lungs. So they open up the lungs, they'll be able to breathe nice and easy. Now, some of them act for a short period of time, while others work for a longer period of time. The main three categories of the bronchodilators is your beta agonists, like your salbutamol and formoterol, antimuscarinic, which is like your Atrovent, and the xanthine preparation, which is the tablets that they take for severe uncontrolled asthma, which is step 4 or 5 on management of asthma, like aminophylline or unifilin. The anti-inflammatory agents or control medication of prophylactic therapy. So these are the ones that will last a lot longer, because we're trying to reduce the inflammation in the lungs to prevent that cascade of inflammation and mucus and constriction and mast cell. The main category that we use is the corticosteroids. So it is your inhaled steroids, and they have a massive place in the management of asthma. Mast cell stabilizers, not as much as in the management of asthma. Leukotrienes antagonists, these have specific, some people will respond to it and they will be on it, and some people have absolutely no response. Anti-IgE monoclonal antibody, so that is more of a secondary care management for severe brittle asthma. And then the long-acting beta agonists. So because they are long-acting, they cover for 12 hours. So they will work very well in association with the steroids. So bronchodilators, so they are used for quick relief of attacks, and these are your blue inhaler mainly, or even the Atrovent as well. Xanthine preparations can be used in hospital as IV, but there's no inhalation preparation for it. Now, how do they work? So they work by a direct beta stimulation, which will increase or stimulate the adenyl cyclase, which increases the cyclic AMP bronchodilation. This will inhibit mediators release from mast cell, increase mucus clearance by increasing ciliary activity. Now, as you can see, the main beta agonists are terbutaline, salmeterol, formoterol. There are other long-acting beta agonists, but not mentioned here. There are non-selective beta agonists like epinephrine and isoprenaline. Now, we don't like non-selective when we talk about medication in the world of medicine and pharmacology. The reason is when something is non-selective, that means the possibility of having side effects is very, very high. The selective ones, as we said, is the terbutaline, salmeterol, and formoterol. These are the ones that work on the ones in the lung. Okay. Salbutamol is the short-acting, and so is the terbutaline. Now, talking about the non-selective beta agonists, like epinephrine, it's a potent bronchodilator. It has a very rapid action, and the effect will only last for 15 minutes. It's very much as in the fight and flight response in the body. It needs to be given by subcutaneous or by inhalation. Has short duration, that's why it's not favorable. It is a drug of choice when we have an acute anaphylaxis reaction. Okay, so they can give it through a inhalator or through subcutaneous. As I said, because it's not selective, it's not effective orally, so we cannot use it there. I don't think we do want to use it there. It can cause hyperglycemia. So if you look at the flight and fight response to the body, there's hyperglycemia because we allow the release of cortisol, which will then cascade into the release of sugar into the blood. So that's a problem for diabetic patients. It can also have cardiovascular system side effects like tachycardia, arrhythmia, hypertension. It can cause skeletal muscle tremor and it's not suitable for patients with hypertension or heart failure. So as you can see, this medication, although it has a place in acute anaphylactic asthmatic attack, the contraindication on the side effects profile of this medication is quite high, so we don't use it that much. When it comes to selective beta agonists, they are more favorable for acute attack of asthma. They are mainly given by inhalation, though it does come as an IV as well. And the short-acting beta agonists like salbutamol and terbutaline. There's the long-acting beta agonists like salmeterol and formoterol. These are the main two that are used within inhalers. Salbutamol, as we said, it can be given through inhalation, whether that is through an inhaler, accuhaler, or a nebulizer. It can be also given orally or through an IV. The same with the terbutaline, it can be given through inhalation, oral or subcutaneous. The oral or the parenteral routes are only given via secondary care because they carry a higher side effects profile, and it's normally used for patients with an acute attack of asthma that is not controlled by inhalation. They have a rapid onset of action, 15 to 30 minutes. Actually, it's a little bit faster than that, but it is recommended between 15 to 30 to reach the maximum effect. They have a short duration of action between 4 to 6 hours, and it is used for the symptomatic relief and treatment of acute attack. Now, long-acting beta agonists, and that is mainly salmeterol and formoterol, they are long-acting beta or bronchodilators. They last for 12 hours, and that's why we give them twice a day. They have high lipid solubility, so they create a diuretic effect even in the lungs. They are mainly given by inhalation. They are not used to relieve acute episode of asthma, as can increase cardiovascular risk and unexplained death. So long-acting beta agonists, once upon a time, there used to be inhalers for long-acting, but they noticed that patients use them and they try to use it as a reliever, just as they use the salbutamol. But they've noticed that the increased use of these medication can increase the cardiovascular risk and unexplained death. And that's why we do not give them as a sole inhaler by themselves anymore. They are now combined with corticosteroid to control asthma, to decrease the number of severity of asthma attacks. They work really, really well when they're combined with a steroid inhaler. Advantages of the beta agonists: they have minimal cardiovascular side effects, suitable for asthmatic patients with hypertension or heart failure because they are selective, they do not affect the heart. The disadvantages is they can still cause some skeletal muscle tremors, and that is mainly in the overuse of these medication. They can increase nervousness. They can, if they are overused, and that's not just the the long beta agonists, but the short beta agonists as well, they can cause tolerance, and after a while they're not as effective. And that's why it's important for us to have the steroid element in the inhaler. They can cause tachycardia if they are overused, because when there is excess of this medication in the lungs, or which goes into the blood, that will have an effect on the beta 1 receptors, which is on the heart. So that causes tachycardia. Muscarinic antagonists, so we have ipratropium and tiotropium. One of them is short acting and the other one is long acting. They act by blocking muscarinic receptors, and they are quaternary derivatives of atropine. They are given mainly through aerosol inhalation, and they do not diffuse into the blood. They do not enter the CNS system, and they have minimum side effects. They have a slight delay of onset of action, and the ipratropium, which is the atrovent, only works between 3 to 5 hours. They still can be used as aerosol nebulizers, and sometimes they can be given through an IV. Tiotropium has a longer duration of 24 hours, and that's why we use it once a day. Now, pharmacodynamics, they are short-acting bronchodilators. They don't last for long. They inhibit bronchoconstriction and mucus secretion. The reduction of the mucus secretion is very important, because we will see why these inhalers are used in COPD. They are less effective than beta agonists, and they have no anti-inflammatory action. They are mainly used in COPD, and they can be used in acute severe asthma in combination with a beta agonist and a steroid. Not much use, to be honest, but some patients will have triple therapy. Methylxanthines, which is theophylline and aminophylline. Now, this is slightly more complicated in the mechanism of action, is slightly longer than the beta agonist and the antimuscarinic. They are phosphodiesterase inhibitors. They will increase the cyclic AMP, which causes bronchodilation. They have an effect on the adenosine receptor antagonist, A1. They increase diaphragmatic contraction, stabilization of mast cell membrane. So they do have quite a lot of different mechanisms of action to help the relief of symptoms. So this shows how that's going to happen with these medication. The pharmacological effect of this class of medication is it causes bronchial muscle relaxation. We said it increases the contraction of diaphragm, so increases or improves its ventilation. Increases heart rate and therefore increase the force of contraction. Increase gastric acid secretion. Increase renal blood flow to the kidneys, so it's a weak diuretic action, just like when we say with the chi. It also causes central nervous stimulation, and that will increase the stimulation of the respiratory center, decreases fatigue and elevate mood. Overdose can cause tremors, nervousness, insomnia, and convulsions. I don't know if many of you know that tea has a bit of this chemical in it, and this is why you can relate this pharmacological effect to the effect of tea. The pharmacokinetics of this medication is it's metabolized by cytochrome P450 in the liver. The half-life is 8 hours, so it needs to be given more than once a day, and that's why it comes as modified release for twice a day. It is also enzyme inducer, so it can interact with other medications. So if you administer that with an enzyme inducer, than like phenobarbital or rifampicin, the metabolism of this medication will be increased. That means the quantity of the medication in the blood will be less. Whilst if you take it with an enzyme inhibitor like erythromycin, then the metabolism of theophylline will reduce, so the medication will last longer in the blood. Now, this is important because it has a narrow therapeutic index. It is used, it says as a second line, but it's not really a second line. I would say it is the fourth step in the management of asthma with accordance with the PDS management guidelines. It is initiated in secondary care. For status asthmaticus, it can be given as slow infusion in hospital to help control the symptoms. Main side effects is, as I said, it has low therapeutic index. So it's important that we monitor the bloods to make sure that it is within range and they don't cause toxicity. Because they have cardiovascular effects, they can cause hypertension and arrhythmia. They can also cause nausea and vomiting. And tremor, nervousness, insomnia, and convulsions are common side effects when we are exceeding that narrow therapeutic index when we go to a higher level. Anti-inflammatory agents. We said that there is anti-inflammatory agents in the management of asthma, and these include the glucocorticosteroids, leukotrienes antagonists, mast cell stabilizers, and anti-IgE monoclonal antibody, omalizumab. How do these work? So they are more of a prophylactic therapy. They reduce the number of inflammatory cells in the airway, prevent blood vessels from leaking fluid into the airway tissues, so reduce mucus building up. Reducing inflammation, they reduce spasm of airways and bronchial hypersensitivity. So glucocorticosteroids, they mainly work through the inhibition of phospholipase A2. They reduce prostaglandin and leukotrienes. They reduce the number of inflammatory cells in the airway. They cause mast cell stabilization, reduce histamine release, reduce capillary permeability and mucosal edema, inhibition of antigen-antibody reaction, upregulate beta receptors, so they have an additive effect on the beta-2 agonist. This is just a quick slide to show you how the steroids works at the very top of the inflammatory cascade to reduce it all the way down to prostaglandins and the receptors. The way the pharmacological action of glucocorticosteroids is they reduce anti-inflammatory action. They work as immunosuppressants effect. They have metabolic effect where they increase hyperglycemia. That's why we see patients who are taking oral steroids have higher sugar levels and they need higher insulin, or they need amendment in their anti-diabetic medication. It also increases protein catabolism and reduces protein anabolism. It's stimulation of lipolysis and fat redistribution. The mineralocorticosteroid affects sodium and fluid retention, and that's why we see some patients on long-term steroids have higher fluid retention. Increases potassium excretion, so it causes hypokalemia. It also increases blood volume, so it causes hypertension. It can have mood effect, so it can cause depression or psychosis. It can affect bone loss by osteoporosis as it inhibits bone formation and reduces calcium absorption. So understanding the pharmacological effect of a steroid will help us manage symptoms or side effects of these medications on the long term. It can be used through inhalation, like budesonide, fluticasone, beclomethasone. These are your main inhaled steroids that we give through an inhalation. They have first pass metabolism because they still go into the blood. If they don't go for the localized, whatever is absorbed goes through the first pass metabolism. It's the best choice in asthma because it has less side effects. We give it orally, like prednisolone or methylprednisolone, when there is an acute exacerbation of asthma. We can also give it as an injection for hydrocortisone or dexamethasone, depending on the severity of the asthma attack. They are not bronchodilators. They reduce inflammation. They reduce the hyperreactivity to the stimuli, just as an immunosuppressant. They have a delayed onset of action. Normally, the effect, especially for the inhaled corticosteroid, takes 2 to 4 weeks. So when I give advice to my patients, I tell them it's not an immediate effect. You start to notice some difference in 2 weeks, maximum effect in 4 weeks. The maximum action can last between 9 to 12 months. It is given as a prophylactic medication, and that's why we say it is the preventative medication and it's not the reliever. It can be used alone if patients have mild asthma, or in combination with a beta agonist as a combined inhaler for a uncontrolled asthma. It is effective in allergic, exercise, antigen, and irritant-induced asthma. So anything that causes an inflammation due to an allergy can be very beneficial to use the glucocorticosteroid. Some steroids can be used as IV, but it is mainly used for status asthmaticus. Inhaled steroids should be considered for adults or children with any of the following features. If they're using beta agonists 3 times a week or more, because that's a sign that their asthma is not very well controlled. And if they are waking up at night at least one night a week, then again, that's a sign that their asthma is not very well controlled with the beta agonist by itself, and they should move to the second step of asthma management. Just in case that you're falling asleep by now, I thought let's add some sound effects. So, clinical uses of glucocorticosteroids. It is mainly used of inflammatory disorders like asthma and rheumatoid arthritis. So, medication that has steroids in it will have inflammation, will need something to suppress that inflammation, and normally our first one is the glucocorticosteroids. It is also used for autoimmune disorders like ulcerative colitis and psoriasis, for organ or bone marrow transplantation, because we are using it as an immunosuppressant. It also have use as an antiemetic in cancer chemotherapy, mainly dexamethasone. So you'll find it as a supplementary medication for patients who are taking chemotherapy. Main side effects of systemic corticosteroids is adrenal suppression, and that's why they should carry a steroid card with them at all times, because that means they will need to have continuous supply of the steroid. It can cause growth retardation in children. It can increase risk of osteoporosis, fluid retention, weight gain, and therefore hypertension. Increases the risk of hyperglycemia. Increases susceptibility to infection because of the immunosuppressant effect, glaucoma because of fluid retention and cataract, fat distribution, wasting of the muscles, and psychosis. Inhalation, because the amount that we absorb through our blood is much less, it has much less side effects. However, it can cause oropharyngeal candidiasis. So we tell them to rinse their mouth or brush their teeth and their tongue after they use the inhalator. It can cause dysphonia, again, voice hoarseness, which is because of the disposition of the medication into the throat. So it's important to give them, to tell them to rinse the mouth afterwards. Abrupt stopping of corticosteroids should be avoided, and those should be tapered. And that goes even if they are on an inhaled, a very high inhaled, because some patients who are on high inhaled doses of steroids for their asthma, they could have eczema as well, and they use steroid creams. So when you look at a patient, don't just look at one route, look at the overall prescribed steroids. We have a patient who is on 3 different routes of corticosteroids, and when we tell her to have a steroid card with her, even MHRA advises patients on high doses of inhaled corticosteroids should carry a steroid card with them. Mast cell stabilizers, this is a bit of an old school, nidoquinone. It can act by stabilization of mast cell membrane, and that has an inflammatory effect. So it's an anti-inflammatory medication as well. Can be given by inhalation, whether it's aerosol, microfine powder, or nebulizers, but has a very poor oral absorption. They're not bronchodilators. They're not effective in an acute attack of asthma because we said it's an anti-inflammatory drug. It reduces bronchial hyperactivity. It's effective in exercise, antigen, and irritant-induced asthma. Children respond better than adults. It can be used in prophylactic therapy, but mainly in children, allergic rhinitis and conjunctivitis, because they have an antihistamine effect, and that's where they affect the mast cell. It's not widely used in the UK. It can be used in other countries, I think mainly in the US. The main side effects has a bitter taste, even as the eye drops, it has a really bad taste. It has minor upper respiratory tract irritation, so burning sensation or nasal congestion. The next type is the leukotriene antagonist, which is mainly the montelukast. It is produced by the action of 5-lipoxygenase on the arachidonic acid. It is synthesized by inflammatory cells found in airways. The way it works is reduces bronchoconstriction, reduces bronchial hyperactivity, mucosal edema, and mucus hypersecretion. Again, it's an inflammation that happens because of the leukotrienes. So if you can see that the Zephyr cross has a place where it reduces the leukotrienes attachment to the receptors. Montelukast is the one that is mainly used in the UK. It is taken orally. It can give the effect of bronchodilation, has anti-inflammatory action, less effective than inhaled corticosteroid, have glucocorticosteroid sparing effect. Okay, so it's not effective in everybody though. It can have effect on certain people. So we trialed for 28 days. If they find that it is giving them a good symptom relief, we continue. If there's no symptom relief, we stop. Okay, so it is used again as a prophylactic. It's not used as for acute attack. It's normally used for mild to moderate asthma. It can be effective in aspirin-induced asthma, in exercise and antigen-induced asthma. It can be combined with the combined inhaler as well. It causes elevation of liver enzymes, headaches, and dyspepsia. In children, it can cause nightmares and psychosis. Omalizumab is a biological medication used in uncontrolled brittle asthma for patients who are not responding very well to inhaled or even oral medication. It is secondary care medication, and it's normally for patients with severe allergic asthma. This just shows how the mast cell can cause the allergic response increase, and that will trigger an asthma attack. Now, last part, hopefully the easier part, which is drugs used in COPD. So COPD is chronic irreversible airflow obstruction. It is caused by lung damage and inflammation of the air sacs alveoli. That could be due to smoking. It could be due to dust, exposure to chemicals, so different factors. But smoking is definitely the highest risk factor in the prevalence of COPD. The way we treat COPD is mainly through non-pharmacological, where we tell them to stop smoking. If it's occupational hazard, then we try to tell them to change their occupation as well. Pharmacological treatment is inhaled bronchodilators, inhaled glucocorticoids, and oxygen therapy. Antibiotics also have a place because of the increased secretion of mucus in the lungs. So if you imagine this highly viscous fluid is in the lungs, they're not clearing it up, it's building up, so it's a nice environment for germs to grow, and that's why they have higher prevalence of chest infections, and that's why we always tell them one of the first things is that they need to have their immunization done, whether that is the influenza or the pneumonia medication and all the vaccination on COVID. So azithromycin, sometimes if patients have recurrent infection, chest infection, more than 3 times a year, then they can go on a prophylactic azithromycin 3 times a week. Lung transplant can be another route as well. The way we look at the treatment of COPD, we look, as we said, on bronchodilator. Now, antimuscarinic are superior, and the reason is because they reduce the secretion of mucus inside the lungs. So if you reduce that mucus production, then reduces the mucus accumulation and reduces the risk of having chest infection. However, we still can use the beta agonists. They can either be used alone or in combination with each other. And now there is a lot more beta agonists and that can be used for a COPD patient. There's also triple therapy, so patients who have traits of asthma and COPD can have a inhaled corticosteroid, a long-acting beta agonist, and a long-acting antimuscarinic medication. So in summary, just shows you how the different medication will affect the cascade of inflammation in the lungs and the response that we will get. So if we look on the bronchodilators, relievers for bronchospasm, we said that the reliever are the beta agonist, short-acting like salbutamol and terbutaline, salmeterol and formoterol for long-acting, antimuscarinic, main drugs for COPD, and the xanthine, like theophylline and aminophylline, which is oral or parenteral. The anti-inflammatory drugs, prophylactic, these are the ones that we give it for long-term use to control their symptoms, which is corticosteroids, mainly inhaled. Prednisone can be given oral where there's an acute exacerbation. Hydrocortisone can be given through IV. Mast stabilizers can be given mainly in children. Interleukins is oral, and omalizumab is injection or subcutaneous in hospital. So this has been quite a lot of slides, I have to say. Any questions?
Can't see anything in the chat at the moment. Does anyone have any questions, guys?
Now, I know the topic of pharmacology is not the easiest topic. I think it's quite specific, and there's pharmacology for each type of drug is different, and I think this is where pharma makes their money, because once you understand the disease, the etiology of the disease, you understand the whole cascade of what happens. That's where new drugs come in, because we are trying to aim for a maximum effect and with minimum side effects. So that's how.
Sorry, I sort of disappeared then. Does anyone else have any other questions at all? Okay. All right. Well, our next forum is in the end of March, where we've got our sort of another session on diabetes, managing diabetes. Back with Chandni, who's been with us a couple of times before. So it should be a really good session. And then, yeah, if you just sign up as you normally do, we'll hopefully see you then. But thank you so much, Hannah, for coming along. That was a lot of information. Do do you think you'd be able to share your slides and then?
Yeah, I will send it to Nisha, and then you can share it with the recording with the rest of the forum.
That would be great. Thank you so much. And people, we can use it as a bit of a reference as well and look back over some of it. But that's great. Thank you very much.
Thank you.